This lecture corresponds to lecture number 10, Vascular Distensibility and Functions of the Arterial and Venous Systems. We're going to do this in two parts. The first part will cover concepts such as distensibility, compliance, something called delayed compliance. We'll review concepts associated with pulse pressure and the transmission of the pulse pressure wave. The second part will include how we take a blood pressure, which we will be doing in lab, mean arterial pressure, and then also the concepts associated with the venous system and venous pressures. So the first thing we're going to cover is something called distensibility. If you notice, there's an equation on the top of this page. This is one of the equations that you actually don't have to remember, so don't worry about memorizing this equation. There'll be plenty more equations that you will have to remember. Distensibility is a concept that is associated with something like, if you think about how easy it is to stretch something, to distend it or stretch it. You think about the difference between a balloon and a automobile tire or a bicycle tire. Balloons are more distensible than bicycle tires, but you can blow up a balloon, and as you continue to blow up the balloon, it will become less distensible. It'll be harder and harder to stretch it. So distensibility is not a constant, but it's still an important concept associated with the pulmonary system, which we'll be covering later. But right now we're talking about the vascular system. Blood vessels are distensible. They can be stretched. So it's significant in that blood vessels can be stretched or distensible is one of the things it says on your screen and in your lecture notes is it allows for non-pulsatile flow at the capillaries. We will look at what happens if vessels become less distensible, what may happen if we can't reduce that pulsatile flow at the capillaries. If by the time blood gets to the capillaries, you want nice, smooth, continuous flow, you don't want the pulsatile flow that you would get, say, in the arteries. Just think about if you cut yourself and you cut an artery, the blood spurts out versus if you cut a vein, blood doesn't spurt out. Flow is very pulsatile from the arteries, but it's not once you get down to the venous system. If you compare the different vessels in your body, veins are much more distensible than arteries, and I've kind of emphasized it. They're 8 times more distensible than arteries. Just kind of keep the number at the back of your mind. Okay, so veins are 8 times more distensible than arteries, because that number is going to come back in a few minutes. The significance of that is they serve as a blood reservoir. And if you remember, and so these are numbers that you have to remember for boards and for my exams, do you remember what % of your total blood volume is within the systemic venous system? And if you remember that, then you remember, oh, I can see why that they're kind of more of a reservoir. There's where we kind of store a lot of our blood. The also thing to remember is that our pulmonary vessels, specifically the pulmonary arteries, are more distensible than systemic arteries. They're 6 times more distensible. That will become apparent, or the significance of that will become apparent when we talk about the pulmonary system. And I might as well just mention a little bit why, mention why it's so significant is when, say, you're exercising and maybe your cardiac output's going up to 30, 40 liters per minute. That blood is going to the lungs, which is a relatively small circulation, and so it has to accommodate a large amount of volume without pressures getting up that high. And one of the reasons it doesn't do that is that the arteries in the lungs are much more distensible than systemic arteries. Now, an even more important concept to know and understand is the concept called compliance. So here is an equation for compliance. It's in red. That's an equation you must know. The bottom one shows you another equation for compliance. The bottom one is showing you is the relationship between distensibility and compliance. They are not the same thing. They are related. So one thing I want you to keep in mind is you think, well, if something's more distensible, it has to be more compliant. But if you look at the bottom equation, it has to also do with original volume too. So you can, for example, have a vessel that's very distensible. So this number may be very big, but with a very low volume. So that may be less compliant than a vessel that may be less distensible but have a higher volume. So distensibility and compliance are related but not the same thing. Why compliance, and I want you to remember this equation, is so important, is it's real important to understand or to know the total amount of blood that can be stored or placed in a given portion of the circulation. And so compliance is also called capacitance. What is the capacity? So if you look at the equation, it's a change in volume for a change in pressure. So I want you just to think about, close your eyes and just envision this. If something is very compliant, if I put a certain volume of blood in that vessel, the pressure will not increase that much. If it's not very compliant, if I put it in the same volume of blood, the pressure will increase much greater. You can look at the opposite way though too. What if I apply a 1 millimeter of mercury pressure to a vessel? How much blood could I get in that vessel? So if I compare two blood vessels and I apply the same amount of pressure, which vessel will I get more volume in? And the vessel that you'll get more volume in is the vessel that is more compliant. So let's do an example. So if I ask you, what is the vascular compliance of a vessel if you had 10 mils of blood and you notice that the pressure increases 10 millimeters of mercury? So calculate the vascular compliance for me. Also, make sure you use proper units. If you set up the equation right, you will have the proper units. So I'll give you a moment to set it up and tell me what the vascular compliance is. What you'll get, if you set it up, compliance is the change in volume, and we put 10 mils in, so that's the change in volume. The pressure changed 10 millimeters of mercury. 10 over 10 is 1 mil per millimeter of mercury. This is these are the units. Now what if I ask you the compliance of that vessel, or another vessel, we'll just say another vessel, that I added 10 mils of blood, but the pressure went up 20 millimeters of mercury. What would be the compliance of that vessel? So you'd set it up the same way, 10 divided by 20, and you'll get 0.5 mils per millimeter of mercury. So which of these two vessels is the most compliant? The vessel is the most compliant is the one with the largest number. So I was able to get more blood in this vessel for the same pressure change. So this top one is more compliant. Compliance doesn't always just refer to blood vessels. We will look at compliance when we look at lungs and what happens with air volumes if the lungs are more or less compliant. So what is so important about understanding distensibility and compliance when it comes down to the vascular system? Well, one of the things is because of the distensibility and compliance, pulsatile flow will be damped to smooth flow by the time it makes its way to the capillaries. If vessels were not very compliant, then we would have a problem with that. Also, one of the things comes down to the characteristics of smooth muscle. If you increase pressure in a blood vessel, what happens is the blood vessel will dilate, and the VD stands for vasodilate. So an increase in pressure will tend to relax the vascular smooth muscle, which helps to increase flow. And that is inherent to smooth muscle, and it is related to distensibility and compliance. Another thing is vessels can serve as storage. So if you're very compliant, you may be able to store a lot more blood than if you were not so compliant. So if you want to compare arteries and veins and why one is more compliant or distensible than the other, it comes down to the structure. If you look at arteries and compare them to veins, there's differences in the number of muscle that's found in the walls. You can look at differences in the amount of elastin fibers and collagen fibers. So I want you to kind of keep in mind a difference between elastin and collagen and even muscle. If you would compare elastin, collagen, and muscle, which one of them can you stretch out the easiest? The one that you can stretch out the easiest would be elastin. The more collagen that you have, the more muscle you have, it'll be harder to stretch. Also comes down to just thickness. So if you compare an artery versus a vein, which of the two is more distensible and more compliant? Well, it's the veins. Veins are not as thick-walled. They don't have nearly the amount of muscle. Now, if I say, what if a blood vessel has changed as a result of a chronic load placed on that vessel, maybe in response to chronically increased blood pressure. Over time, you may get vascular remodeling. So you can get a little bit more smooth muscle that builds up. You can actually get hypertrophy of smooth muscle in blood vessels. Or maybe if you had some damage to a vessel, you can get some collagen put down, which is fibrous, more fibrous connective tissue. Those vessels are going to be less compliant and less distensible. If you look at this picture, which differs from your manual, so just look at this and don't look at your manual, because I've gotten rid of a couple of the few of the curves that you have on here. I want you to look at this pressure volume curve to see a couple important things I want you to get from it. If you're not a picture person, it's going to be hard. So if you're not a picture person, just close your eyes and just listen. Okay, but at some point you might have to open your eyes. A volume pressure curve is showing you a relationship between volume, which we have on the x-axis, and pressure, which we have on the y-axis. The line that we have to the far left, which is very, very steep, represents a volume pressure curve or pressure volume curve. You can use them interchangeably for the arterial system. The one on the right, which is not quite as steep, represents a volume pressure curve obtained from the venous system. So what kind of bits of information can you get from this picture? One, if you look at the volume, just look at the volumes for the arterial system versus the venous system, you automatically can see there's a huge difference in volume between the arterial system and the venous system. And you already knew that without even looking at it. So Dr. Kayes told me most of your resting blood volume is in the systemic venous system. It's true, I didn't lie. Okay? So one, you already know there's a difference in volumes between the venous and the arterial system. What else you can pick up from the curve is compliance. Compliance you can get from looking at how steep the slope of the curve. If the slope is very steep, like you see over here in the far left, that means not very compliant. The less steep the slope, the more compliant. So if you notice the arterial system, for a very small change in volume, pressures go up quite a bit versus the venous system. You can increase the volume, pressures don't go up that much. So what's so significant about that? When you get a blood transfusion, where do they inject you to transfuse the blood? Do they put it in your arteries or do they put it in your veins? One, they put it in your veins for more than one reason. They put it in the veins because it won't mess up what's going on in your circulatory system as well, or as much as if they put it in the arterial system, because then it can accommodate a good amount of blood without the pressures changing too much. Also, just think about, I had mentioned earlier, if you had cut an artery that pressure behind it. It's going to pulse out that blood, and you're going to lose blood fairly quickly. It's easier. And also if you give blood, they always take it from your venous system versus the arterial system. Now, if you look at the same volume pressure curve with the other curves placed on it, what that is trying to show is the effects of either stimulating the sympathetics or inhibiting the sympathetics on compliance or capacitance. And we could also say on volumes. So this is the one instance where I really don't care for the picture. So just think about what would happen if you stimulate the sympathetic nervous system and its effects on blood vessels. If you activate the sympathetics, blood vessels in general will constrict. I don't care if it's arteries or the veins. So if you constrict a vessel, what happens to blood volume? So here we have a vein, the venous system, and I stimulate the sympathetics. What happened to blood volume? It's less. So if you stimulate the sympathetics, capacitance decreases. It applies to the venous system or the sympathetic system, which will play a role when, say, for example, you're exercising. When you exercise, you're going to constrict some of the veins so you can borrow some blood from the venous system and get it into the arterial system so you can get higher than normal cardiac outputs. Now, everything does come down to, okay, what is innervated? You have to know which blood vessels are innervated, what's also going on locally. And that will be subsequent lectures. But think about why you would want to constrict a blood vessel and ultimately decrease the volume of the vessel. Sometimes it's important to do that. If you inhibit the sympathetics, the blood vessels will expand or dilate and volumes will increase. Now, another topic that is extremely important to understand when it comes down to blood vessels is something called delayed compliance. Now, what we're about to see and look at on this picture is something that is inherent to vascular smooth muscle. The response, they inject a certain amount of blood into a blood vessel. You'll notice pressures increase. Well, I expect if you put a certain volume of blood in a confined space, pressures will increase because it's going to push out along the sides of the walls, which creates pressure. But what you'll notice is over time, the pressures start to decline, but not all the way back down to normal. But it's like, why is the pressure starting to decline? The reason is as it's exposed to the increased volume, you stretch out the vessel, the pressures will drop because the vascular smooth muscle is going to start to relax. And what you're seeing is some people call stress relaxation. So it starts to relax, and as it relaxes, the vessel expands to accommodate that blood, and therefore pressures start to decline. And what you're seeing is a partial compensation. So pressures start to decline back to normal, but not exactly to normal. You can see this concept of delayed compliance if you remove volume from a vessel. So if you initially remove volume from a vessel, pressures will drop, but over time, even despite that decreased volume, pressures will start to increase because what will happen in this case, the smooth muscle will start to contract to get the pressures back up towards normal. So this is kind of what we refer to more as some sort of compensation for changes in volume. This is how it's an inherent or innate ability of vascular smooth muscle to adjust to changes in volume to try to maintain proper function of the cardiovascular, or I should say just the vascular system. So I'll give you kind of couple scenarios where this would hold true and why it would be significant. If you were hemorrhaging, losing blood, you'd be over here in this scenario. If you hemorrhage, your blood, you can significantly lose blood, your blood pressure will drop, and blood pressure is real important for perfusing tissues and get oxygen and nutrients to the tissues. You don't want that to happen. So one of the ways that we can try to compensate for the drop in pressure that you would get with decreased volume is this delayed compliance. It's just a partial compensation. We're going to have some nervous system reflexes and other things that will play a role in our response to hemorrhage. The other scenario would be, if, where you see over to the left, would be if I over-transfuse you with blood, which happens. If you get too much blood transfusion, pressures would go up, and that could damage vessels. It can cause some problems. So one of the ways we try to compensate for that increased pressure that could result from an over-transfusion is, again, this delayed compliance. Now you'll notice delayed compliance applies to both scenarios, either a response to increase in volume or a response to a decreased volume. They refer to both of them as stress relaxation, which I do not like, because in this scenario over here, that is the only one which the smooth muscle relaxes. But they do use these terms interchangeably. I will not, though. But just so you know, they do use the delayed compliance and stress relaxation interchangeably, but I do not. Now, another thing that we have talked about in the past that we're going to talk a little bit more in depth now is pulse pressure. So when we did the lecture on cardiac cycle, I drew out an aortic pressure recording, and we indicated what was systolic blood pressure, the diastolic pressure, and what the pulse pressure was. And one of the equations for pulse pressure we gave you was systolic minus diastolic blood pressure. That's one equation. But here's another equation that you must know. Think of this is more of a conceptual equation, but I also can use it mathematically, and we'll be doing that in lab. I'll give you some case studies where I give you someone, say, stroke volume. That's what the SV stands for. The C is compliance. If I give you these, you can still calculate someone's pulse pressure. So I may not give you that person's blood pressure, but I want to kind of emphasize again the significance of a pulse pressure. Pulse pressure can give you important clinical information. A normal pulse pressure is around 40 millimeters of mercury. If it's too high, it can indicate certain things, or if it's too low. The pulse pressure or if you take someone's pulse, what you're feeling, remember, if you're taking someone's pulse, what you're feeling there is the pressure wave that's created when the blood is leaving or moving away from the aorta. When the aorta recoiled, because it was stretched out, it recoiled, sending the blood distally, but the pressure wave is actually sent ahead of the volume, ahead of the blood. And what you're feeling is that recoil, or that pressure wave that was created by the recoil of the aorta, and you're feeling a pulse. So you can take someone's pulse to get their heart rate, but you also could look to feel how that pulse feels. Is it real strong, or is it real weak? And the pulse pressure, if it's really high, the pulse will feel strong. If it's real low, it may feel weak or may be absent. So if you look at a couple things just this way, what couple things can influence the pulse pressure? If you know this first equation, then you can tell me. Pulse pressure is influenced by systolic pressure. It can be influenced by your diastolic pressure. So if you increase your systolic pressure but don't change diastolic, your pulse pressure would increase. If you decrease the systolic, it would decrease. If you keep systolic pressure the same but you change diastolic, what would happen? So if you have a very high diastolic, your pulse pressure would be small. If you have a very low diastolic pressure, your pulse pressure would be high. So that's one way of looking at pulse pressure. Another way is using these concepts of stroke volume and compliance. So I'm going to be looking at that in a second, but I want you to look at this picture. Things that can influence your systolic or your diastolic pressure. I'm just going to look at a couple of them. So if the aorta was rigid, it wasn't distensible, how would it influence these pressures? Well, we had kind of talked about it when we talked about the aorta in regards to the cardiac cycle. And remember, we'd mentioned it acts as a secondary pump. And it's a secondary pump because it's an elastic vessel. It's distensible. You can stretch it. Well, if the aorta became rigid, the systolic pressure would get really high. If also you would not be able to maintain the diastolic pressure, if it was less rigid, it wouldn't be able to maintain that diastolic pressure and it could drop to really low. What if you have changes in your arterial system where maybe blood vessels were becoming calcified or rigid? The resistance, peripheral resistance, may be affected, which could also affect diastolic pressure. So various things can influence these pressures. Here's one that we're going to encounter when we talk about exercise, so I might as well mention this one. If your blood is moving away from your heart and out of the aorta very quickly, diastolic pressures can drop significantly, because what's creating the pressure in the aorta is the blood sitting there. But if you're draining it out of the aorta very quickly, diastolic blood pressures can drop, which can happen when you do severe isotonic exercise. So in lab, we may get people who can get their heart rates up really high, they're working real intensely, and someone takes their blood pressure, you're going to notice that their diastolic blood pressures drop. And some of them you'll be like, wait, I hear everything all the way down to zero, in which we're going to explain to you how to take a blood pressure in the second part of this lecture. But diastolic blood pressures can drop significantly if you have really very fast heart rates and if your blood vessels peripherally are dilated. It's getting all that blood to those peripheral blood vessels. Now, the other things that I want to talk about in regards to pulse pressure is stroke volume divided by compliance. Think of it as a conceptual equation, but also you're going to have to do some math. So it's math and a conceptual equation. If you look at the equation, how could these two factors influence someone's pulse pressure? If I increase stroke volume, what's going to happen to pulse pressure? Okay, since it's on the numerator, if I increase this top number, pulse pressure would be higher. If I decrease stroke volume, pulse pressure would be lower. Look at the bottom one, compliance. What's the relationship between compliance and pulse pressure? If you increase compliance, pulse pressure would be lower. If you decrease compliance, pulse pressure would be higher. So let's see if we can apply this to some conditions that may occur in a patient. So what we're seeing here is a normal pulse pressure curves here on the left, and we're comparing it to what we would see with some other conditions. So you'll notice, let's do aortic stenosis. That one's the easiest. Okay, so with aortic stenosis, you notice that the pulse pressure curve is not as high. The pulse pressure is lower. So what was the issue with aortic stenosis? The aortic semilunar valve was narrow. So it's hard to get blood out of that narrowed opening. And what could happen to stroke volume? Stroke volume would be less. So pulse pressure is stroke volume divided by compliance. And so with people with aortic stenosis, they could have a reduced pulse pressure because of a diminished stroke volume. So that one makes sense to me. Let's look at arteriosclerosis. This literally means hardening of the arteries, or the artery, sorry. You can have arteriolo sclerosis, which is hardening up the arterioles. This could be a consequence of long-standing atherosclerosis, but not necessarily. But you have some changes occurring with the arteries where they're becoming sclerotic or stiffer. And so what you notice is their pulse pressures are higher than normal. So why is their pulse pressures higher? Well, in this case, the vessels are less compliant. So if pulse pressure is stroke volume divided by compliance, something that's less compliant, this pulse pressure can be higher. So these two, not bad. Not hard to try to understand. Here's was a tricky one, aortic regurgitation. Look at the pulse pressure curve and tell me what's absent from that curve. We know it's bigger than these other ones, but how also does it differ? You'll notice it doesn't have a dicrotic notch. And why doesn't it have a dicrotic notch? Because the dicrotic notch is created by closure of the aortic semilunar valve. It doesn't close with aortic regurgitation. That's why no dicrotic notch. But you'll notice that with people with aortic regurgitation can have extremely high pulse pressures. Systolics can be high, diastolics pretty low. So let's kind of figure out why it's this way. So this one's a little trickier. So you're like, well, why shouldn't aortic regurgitation have a low pulse pressure? Because aortic regurgitation can have a low stroke volume. That's true. But think about it this way. If you initially eject the blood out of the heart into the aorta, and that blood all of a sudden goes back into the left ventricle, a lot of that blood in the left ventricle, the effective stroke volume is diminished, yes, because you're not going to get as much blood from the aorta out to the rest of the body. But what happens is all the extra blood going in the left ventricle stretches it out. And if you remember Frank Starling, what's going to happen? More volume, more stretch, and what happens? The ventricles are going to contract more forcefully, and when it does, pressures are going to go high. And so with more forceful contraction, you got more blood initially leaving, the systolic blood pressure will be high. But it drops fairly quickly down, could be down to zero, doesn't have to be to zero, but can draw down to zero because that blood is going back into the ventricle, out of the aorta. Without that blood there, without the pressure, pressures in the aorta are going to drop significantly. So the presence of the blood there in the aorta is what creates that pressure, and we're doing a pressure recording obtained from the aorta. And so you can have very high systolic, but the diastolics drop because all that blood's going back into the left ventricle. So with people with aortic regurgitation can have extremely high pulse pressures. And what they could have is something that I want you to remember, because this may appear on Part 1 or Part 2 boards. Part 2 boards, generally where you might see it, is people with aortic regurgitation can have what we call a bounding or a hammer, or they call it a water hammer pulse. And when you're feeling their pulse, what you feel is a very strong pulse, but it gets weak real quick. Real strong, real weak. Real strong, real weak. And that is what you're feeling, is that strong was that left ventricle pumping out that blood really quick into the aorta. That aorta recoils, but a lot of that blood goes back in the aorta. You've got that pressure wave coming down, and that's what's creating the pulse. It's not the blood, it's the pressure. But it gets real weak because that blood moves back into the left ventricle. So they have what we call a hammer or a water hammer type, or a bounding pulse. You may also have pretty high pulse pressures with people with patent ductus arteriosus. Now, this is a congenital defect in which the ductus arteriosus does not close after birth. It remains patent or open. Remember the ductus arteriosus, if you remember some anatomy, some embryology, or fetal circulation, it's a connection between the pulmonary trunk and the aorta. If it doesn't close, what's going to happen is the blood leaves the ventricle, goes out the aorta, but instead of going, a lot of that blood going to the systemic circulation, it's going to go through the ductus arteriosus back into the pulmonary circulation because it wants to go from a high to low pressure. And the pulmonary circulation is a lower pressure. So what will happen is a significant amount of blood will get out of the aorta very quickly back into the pulmonary system, and so the pulse or the diastolic pressures can drop quite a bit because you're losing that blood out of the aorta very quickly. Systolic pressures are going to be high because that blood eventually is going to go back into the left ventricle with all the new blood. So it's going to go pulmonary system, left atria, left ventricle. So you have high systolics and low diastolics with people with patent ductus arteriosus. So these two bottom conditions, well, and also arteriosclerosis, are all associated with high pulse pressures. The bottom two can have extremely high pulse pressures. And so one thing that I want you to kind of put in the back of your mind is if I cannot reduce that pulse pressure, which should happen as we move through the circulatory system, because we'd mentioned it earlier in an earlier lecture. Remember, the resistance arterial's job is to reduce both mean arterial pressure and pulse pressure by the time you get to the capillaries. If it's so high, it'll be very difficult to reduce that pulse pressure, and you'll get pulsatile flow in the capillary beds in these people. Now, you can probably figure out, or you may have experienced pulsatile flow in real life, where if you maybe cut yourself and you felt your finger throbbing or something, and what you're having, if you say cut yourself, is what you're feeling is you can't, or you get significant amount of dilation, blood flow to wherever that injured area is, and the pulse pressure can't be reduced significantly, so you're just feeling the throbbing, and what you're feeling is the pulsatile flow. And it's what you're feeling is that the pulsatile flow is in the capillaries. Now, couple three terms in regards to pulse, and this type's not really pulse pressure, but it's pulse. They're kind of related. Is if you take someone's radial pulse. You take someone's radial pulse. Most of you are like, okay, I'm feeling the pulse, get the heart rate, but you're also doing to see how it feels. You're going to have a hard time getting the pulse rate if that pulse is weak. So the first definition is a weak pulse. So if you have a weak pulse, the pulse that you feel, what you feel, it's faint or diminished in strength. You can't easily feel it. So that would be considered a weak pulse. What type of things could result in a weak pulse? Well, decreased cardiac output. If you don't have a lot of blood leaving the heart, you're not going to get as much recoil of the aorta. Not as much recoil, you're not going to generate as great of a pressure wave, and by the time you make it way to your hand or your wrist where you're feeling the pulse, you're not going to feel much. Other thing could cause a weak pulse, low blood volume. That can cause a weak pulse too. I want to skip to the bottom one and I'll come back to this middle one, a pulse deficit, because we'll be doing this in lab. We'll see if your partner in lab has a pulse deficit. You will be taking your radial pulse while your partner takes your apical pulse. So you're taking the pulse on the same person. If I take your apical pulse, which is over the apex of the heart, which would be that mitral site, and you do the radial pulse, they should be identical. They should be the same. But if you have the radial pulse is less than the apical pulse, that is a pulse deficit. It can't occur any other way. You cannot have an apical pulse less than the radial unless you have some sort of ectopic tumor generating its own pulse from your heart down to that blood vessel. I doubt that's going to happen. What you only can get is if a radial pulse is less than the apical. So why does that happen? Now, if you take someone's pulse, remember what you're feeling, again, is that pressure wave that's created by the recoil of the aorta. If you, for example, have a diminished amount of blood leaving the heart, you're going to get less recoil. And so by the time it makes its way down to your wrist and you're feeling that pulse, you may not feel it because the blood is coming, just not as much blood, but that pulse pressure wave was diminished significantly enough that you're not going to feel the pulse because it didn't start off high to begin with. And so you got your apical pulse, which is right over the chest wall, the heart beat. It pumped the blood out, but it was pumping out less blood. And so what you have is what we call a pulse deficit. They say if you have a pulse deficit over 5, the difference in 5 beats between the apical and radial, then you should refer to a cardiologist. Now, some people know they have pulse deficits under certain conditions. For example, if you have premature contractions, while you're having those premature contractions, you will have a pulse deficit. So I know if I'm having my premature atrial contractions, I have a pulse deficit. And if it's lasting a certain amount of time, I will have more than 5 in a minute. So if I'm taking my pulse within a minute, I know I'll have more than 5. Generally it passes and I'm okay. But if this is exhibiting or occurring a lot, then you probably should see a cardiologist. When I have this, if I'm feeling my pulse, what I feel is I feel pulse, 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 nothing. Pulse, 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 nothing, nothing. I've done this while taking an ECG simultaneously, and I'll notice when I have my premature contraction, that's where I lose the pulse because I'm not filling up my heart as much or my ventricles, and so my blood leaving the heart's not as much, and so my pressure wave won't be as high. The last topic is something called pulsus paradoxus. So I have the definition here. So normally you have a variation in your pulse while you're breathing. I've tried to feel this in me, I can't notice, but there is a normal variation that if you inhale, your pulse feels weaker. It becomes stronger as you exhale. So why is this a normal variation? So you normally do have the pulse become slightly weaker as you inhale and stronger as you exhale. So if you think about what I had mentioned a while ago about splitting of S2, if you inhale, you bring more blood to the right side of the heart. But because of that drop in thoracic pressure as a result of inhalation, those blood vessels in the lungs expand, accommodates more blood, and there'll be less blood going to the left side of the heart. All right? Well, if you have less blood going to the left side of your heart, that means less blood coming out of your heart, and so the pressure wave is going to be smaller and it's going to feel weaker. Your pulse will feel weaker. So that's why you have a normal variation. Most of us will not pick that up. I can't pick it up. There is normal variation. People with pulsus paradoxus, it's exaggerated. It's much greater than someone that's normal. What they'll do is there is some normal variations in blood pressures when you breathe. In someone with pulsus paradoxus, it's very much exaggerated. So generally you see something like pulsus paradoxus with, it could have cardiac or pulmonary causes. Pericarditis is one of them that can lead to pulsus paradoxus. That's just one example that you can have pulsus paradoxus. Now the last topic that I'm going to cover prior to taking a break is the pulse pressure transmission, or the transmission of that pulse pressure wave. So I've repeatedly talked about that when the blood leaves the heart and goes in the aorta, stretches out the aorta, but then the aorta, because it's elastic, recoils, and sends the blood distally, but it creates a pressure wave that's transmitted faster than the actual blood. As it's transmitted, it becomes dampened. And a couple things contribute to damping of that pulse pressure wave. The R is resistance and the C is compliance. So resistance makes sense. It's easier to explain. As the blood is encountering more and more resistance, you're going to those resistance arterioles, these vessels that are smaller, and they're providing more resistance to flow, that will reduce that pressure wave. What about compliance? According to the equation, the higher the compliance, the more damping that occurs. So you start getting some damping in the aorta because the aorta has got some compliance to it. But if you compare an aorta to an artery to an arteriole, just a single aorta to a single arteriole to a single, or artery to a single arteriole, compliance decreases if you're looking at an individual vessel. And one thing I do want to mention, it is in your notes, well I remember, is that transmission of the pressure wave is, or how fast it's transmitted, is related to compliance, and it's inversely related to compliance. So the less compliant the vessel, the faster it's transmitted. So if you compare aorta versus arteries versus arterioles, the larger the artery, the slower that pressure wave is transmitted. So as it moves down, it speeds up, speeds up, speeds up as it moves away from the aorta. Well, if you say, well, if I look at this equation for damping, according to this, if you're more compliant, you dampen it more significantly. But the compliance significantly will increase in the arterioles, because what we're seeing is aggregate compliance. Remember we talked about cross-sectional area and its relationship to velocity of blood flow? Same thing when we talk about compliance. We're going to be looking at aggregate compliance. You're looking at a lot of arterioles arranged in parallel versus not so many arteries. So total compliance of the arterioles is much greater than the arteries. And so you get significant damping of that pressure wave through those arterioles, and specifically the resistance arterioles. So it dampens that pressure wave, so it's diminished. So by the time eventually you hit to the capillaries, you don't have that pulse pressure anymore. You have smooth, continuous flow to the vessels. So before you take a break, I want you to answer these 5 questions. Okay? So get a piece of paper, write in your manual, the answer to these questions without, see how much you remember without looking back at your notes. So question number 1, which vessels are more compliant, veins or arteries? Okay? That's 50-50. Number 2, what is the equation for compliance? Number 3, what happens to vascular smooth muscle if volume increases in the vessel? Number 4, what are the equations for pulse pressure? I taught you 2 equations. Write them both down. And last one is, why is pulse pressure decreased in aortic stenosis? What is the reason why it's decreased? Now one thing, actually, I'm going to answer number 1 for you now because I forgot this, and it's in your notes, but I wanted to mention it. The vessels that are more compliant are veins. And do you remember at the very, very beginning where I asked you how more distensible, or not distensible, how more distensible that veins were than arteries? And the thing was, they're 8 times more distensible. Okay. Well, how does that relate to compliance? So one of the equations for compliance, which I said you don't have to memorize, was distensibility times original volume. Well, veins are 8 times more distensible and have got 3 times the volume. So how much more compliant are veins? A heck of a lot more. So if you do the math, they are 24 times more compliant. Write that number down. It is in your manual, but write it down again. So veins are 24 times more compliant than arteries. What was so significant about veins? Their job as storage. All right, so we're going to take a break. When we come back, we'll continue on.